Imagine a patient comes in with a painful mass near their knee,
Right.
and a well-meaning doctor, just trying to get a quick diagnosis, sticks the needle into that mass to biopsy it.
Happens all the time.
Yeah. But what that doctor doesn't realize is that by pulling that needle out, they might have just guaranteed the patient's entire leg will have to be amputated.
It is a terrifying reality.
It is. And welcome to the deep dive. Today we're really immersing ourselves in the high stakes, totally uncompromising world of orthopedic surgical oncology.
Absolutely, because it's a field where, literally 1 millimeter of miscalculation can alter a life forever.
Yeah.
We are working directly from the definitive source on this. We're looking at excerpts from the second edition of Operative Techniques in Orthopedic Surgical Oncology.
Edited by Malawer, Wittig, Bickles, and Weasel.
Exactly. And, if you are a medical student prepping for your rotations or a young surgeon refining your approach, or really just someone fascinated by the absolute extremes of human skeletal engineering, this deep dive is completely constructed for you.
For sure. Because we are going to trace the evolution from an era where radical amputations were like the only answer to the limb-sparing miracles we see today.
It's a huge shift.
Yeah. But we aren't just going to list surgical steps. By the end of this deep dive, you are going to understand the physiological why behind these intense surgical decisions.
Right. From primary sarcomas to metastatic disease and through the incredibly volatile anatomy of the pelvis and the extremities.
To understand how we save limbs today, we basically first have to understand why we used to cut them off.
Precisely. If you look back to the 1970s, the accepted treatment for a primary bone or soft tissue sarcoma in an extremity was just a high-level amputation.
Wow.
Yeah, the philosophy was simple but devastating. You remove the entire limb to absolutely guarantee you got all the cancer. But today, thanks to the techniques codified in this text, 90 to 95% of all these sarcomas can be treated with limb-sparing surgery.
That is an unbelievable paradigm shift. And reading through the history, it's clear this wasn't just driven by, better chemotherapy.
No, not entirely.
It was driven by surgical pioneers who fundamentally reimagined how tumors interact with human anatomy. Giants like Francis and Markov, but particularly Dr. William F. Enneking.
Enneking was really the visionary who gave limb-sparing surgery its biological foundation.
Right.
He developed the initial musculoskeletal tumor staging system.
Right.
Because before Enneking, surgeons just saw a tumor in the bone. But Enneking looked at the anatomical compartments and the fascial borders.
Okay.
He realized that tumors don't just spread randomly, they actually respect certain anatomical barriers, like thick fascial tissue or articular cartilage, at least for a time.
Right. Let's unpack this, because the analogy that comes to mind is like structural fire containment.
Oh, that's a great way to look at it.
Yeah, like in the old days, if a fire broke out in a massive apartment building, the solution was to demolish the entire city block.
Right, which is the amputation.
Exactly, that's the amputation. But Enneking realized that human anatomy has built-in firewalls, the fascial borders. So you don't have to demolish the block, you just surgically resect everything up to the intact firewall.
That is exactly the biological mechanism at play. And recognizing those firewalls led to the 3 interdependent pillars of modern limb-sparing surgery.
Okay, what's the first one?
So the first pillar is the resection of the tumor itself. And the absolute mandate here is avoiding local recurrence. You do not just scoop out the visible tumor.
Because that leaves cells behind.
Right. You must execute what we call strict oncologic margins. This means resecting a continuous cuff of completely healthy, normal tissue entirely surrounding the tumor block.
Because if you breach that tumor capsule, you risk spilling microscopic satellite cells into the surgical bed, which effectively seeds a brand new tumor.
Exactly. And once you perform an adequate bone tumor resection with those wide margins, well, you are left with the second pillar.
Which is the skeletal reconstruction.
Right. The text highlights that the average skeletal defect after a resection is 15 to 20 centimeters.
Wow.
You have removed a massive structural load-bearing segment of the patient's skeleton.
So how do you fix that?
To bridge that gap, surgeons utilize customized modular prosthetics or massive allografts.
Which brings us to the third pillar, and honestly, the one that blew my mind the most.
Just soft tissue.
Yes, soft tissue reconstruction and muscle transfers, because you can't just bolt a massive titanium and cobalt chrome endoprosthesis into someone's leg and, stitch the skin back over it.
No, the biomechanics don't work at all, and the infection risk would be catastrophic.
It would just fail, right?
It would fail immediately. A metallic prosthesis sitting right under the skin will eventually erode right through.
Yeah.
So you have to perform intricate muscle transfers to create a vascularized biological envelope around that hardware.
You're basically transferring living muscle.
Yes, you are transferring living muscle to cover the neurovascular bundles, restore motor function that was lost during the resection, and provide the robust blood supply necessary for primary wound healing.
Okay, so that three-pillar strategy: resect the tumor with wide margins, rebuild the skeletal defect, reconstruct the soft tissue envelope. That is the gold standard when you are dealing with a primary bone sarcoma.
Correct.
But the text makes a massive strategic pivot when we talk about metastatic bone disease, or MBD.
It really does.
This is when the cancer originated in the lungs, the breast, or the kidneys and has seeded into the bone. The entire surgical math changes.
It has to change because the systemic reality of the patient has changed.
Right.
With a primary sarcoma, your surgical goal is a systemic cure.
Yeah.
You're operating to save their life from that specific local tumor.
But with MBD?
With metastatic bone disease, the disease is already systemic. So the primary goal of orthopedic surgery for MBD is not a systemic cure.
What is it then?
It is achieving local tumor control, alleviating severe pain, and providing immediate structural stability to prevent what we call an impending pathologic fracture.
And the threshold for an impending fracture isn't just a surgeon looking at an X-ray and guessing, right?
No, not at all.
The text provides a rigid mathematical formula. It defines an impending fracture as a painful olytic lesion that is greater than 2.5 centimeters in diameter and occupies more than 50% of the cortical diameter of the bone.
Correct. At that specific threshold, the biomechanical integrity of the cortex is mathematically compromised.
So it'll just break.
Yeah, the sheer forces of normal physiological loading, just standing or walking, will cause that bone to catastrophically fold and snap.
But the decision to operate isn't automatic just because they hit that 50% mark, is it?
No. The patient's history and baseline functional status become the ultimate deciding factors. You aren't going to subject a patient to a grueling, massive lower extremity resection and reconstruction if they are, already bedridden with end-stage systemic disease.
Right. The physiological toll of the surgery has to be justified by the functional outcome.
That is a critical clinical judgment. You have to consult with the medical oncologist. But if the patient is a candidate, the surgical sequence for MBD is absolute.
Tumor resection first, then reconstruction.
Exactly. You create a large cortical window in the bone, use hand curettes to meticulously evacuate the gross tumor mass, and then you absolutely must use a high-speed burr drill on the entire cavity.
I really want to focus on that high-speed burr because it's not just about scraping bone. It's about the physical mechanism of tumor eradication, right?
It is. Hand curettes alone will leave microscopic disease hiding in the little microscopic ridges of the cancellous bone.
So the burr gets those.
Right. The high-speed burr physically grinds away the walls of the cavity, but it also generates intense localized heat and friction.
Oh, wow.
And that heat causes thermal necrosis of any remaining microscopic tumor cells in the margins.
So it's basically cooking the remaining cancer cells.
Yeah, that thermal effect is a vital adjunct for local control. You have to aggressively prepare that cavity before you even think about stabilizing the bone.
Okay.
And when you do reconstruct it, the material choice is strictly dictated by the patient's biology. For metastatic disease, you must use cemented internal fixation. Biologic reconstructions, like bone grafts, are strictly contraindicated.
Wait, why is biologic reconstruction inappropriate for metastatic disease? If we are trying to rebuild the bone, wouldn't a natural biologic graft be better than just packing it with cement?
It's a great question, but you have to look at the biology of an MBD patient. They are fighting a systemic illness, their nutritional status is often compromised, and they are likely undergoing radiation or chemotherapy.
Oh, I see.
All of those things actively inhibit bone healing. A biologic graft takes months, sometimes a year, to incorporate. These patients do not have the luxury of time.
Right. They need to be able to bear weight and get out of bed immediately.
Precisely. Polymethyl methacrylate, or PMAA bone cement, provides exactly that. It cures exothermically in minutes, creating an instant, rigid interlock between the metallic hardware and the remaining host bone.
So it's instantly strong?
Yes. It provides immediate structural stability, allowing the patient to mobilize the very next day, which drastically improves their remaining quality of life.
Okay, so we've established the divergent rules of engagement here. Systemic cure for primary tumors and immediate structural stability for metastatic disease.
Right.
Now, the text applies these rules to the most complex, high-stakes anatomical regions in the human body. Let's start with the upper extremities, specifically the shoulder girdle.
Okay, so the proximal humerus is the third most common site for osteosarcoma. And what makes this region uniquely treacherous is that tumors here have a high propensity for extraosseous extension.
Which means?
They don't just stay inside the marrow cavity, they break through the cortex and violently invade the surrounding soft tissues of the axilla and the shoulder joint.
Wow. Which leads to the Tickhoff-Lindbergh procedure.
Yes.
If you were listening to this and trying to visualize it, imagine a surgeon removing the entire top half of your humerus, the shoulder joint, and large sections of your clavicle and scapula.
It's extensive.
But miraculously, your arm remains attached, alive, and functional, suspended essentially by carefully preserved muscles and blood vessels. I mean, it sounds like science fiction.
It is a masterclass in anatomical salvage.
Yeah.
But the absolute dictating factor, the biological line in the sand that determines if a Tickhoff-Lindbergh is even possible, is the tumor's relationship to the neurovascular bundle.
Okay.
The brachial plexus and the axillary vessels run right through this corridor. If the extraosseous extension encases those vital structures, limb salvage is just impossible, and a 4-quarter amputation is required.
Man. Well, if the shoulder is a high-wire act, the pelvis is on an entirely different level of chaos.
Oh, absolutely.
Here's where it gets really interesting for me, because working in the pelvis sounds like trying to defuse a bomb in a crowded utility closet.
That is exactly what it feels like.
You have the lower gastrointestinal tract, the urinary tract, reproductive organs, and major neurovascular trunks like the sciatic nerve and iliac vessels, all crammed into a tight, three-dimensional bony ring. How does a surgeon not get lost?
Well, remember, a massive pelvic sarcoma distorts all the normal soft tissue planes you would usually use for navigation.
Right.
You are operating deep within a cavity where everything looks completely abnormal.
Yeah.
Therefore, the surgeon has to rely on easily palpable, fixed, bony landmarks.
Like what?
You're constantly feeling for the anterior, superior iliac spine, the ischial tuberosity, and the greater trochanter. Those fixed points are really the only reliable maps to systematically expose and protect the critical structures.
The resections here are categorized into 4 types, right?
Yeah.
Type 1 is an iliac resection, Type 2 is periacetabular, Type 3 is the pubic or pelvic floor, and Type 4 is hemipelvic. But Type 2, the periacetabular resection, poses a terrifying biomechanical problem.
It does, because you are removing the acetabulum, which is the actual hip socket. The pelvic ring is a closed biomechanical loop designed to transfer the entire weight of the upper body down into the legs. The moment you resect the hip socket, that load transfer is just obliterated.
So how do they walk?
Well, reconstructing a stable weight-bearing joint in a massive pelvic void using custom prosthetics or saddle implants is arguably one of the most technically demanding feats in all of orthopedics.
And the terminology around these pelvic resections is crucial. The text distinguishes between an internal hemipelvectomy and an external hemipelvectomy.
Right, huge difference.
An internal hemipelvectomy is a limb-sparing procedure. You resect massive portions of the pelvic bone, but you preserve the neurovascular supply and save the patient's leg.
Okay.
An external hemipelvectomy is an amputation, the removal of the entire lower extremity and half the pelvis.
And if you are performing an internal hemipelvectomy, closing that massive surgical void requires really sophisticated myocutaneous flaps.
Which is tissue transposed with its blood supply completely intact.
Yeah. Right. You have the classic posterior flap, which utilizes the gluteus maximus. But if the tumor has invaded the posterior buttock, you have to pivot to an anterior flap, recruiting the femoral vessels and the anterior thigh compartment.
Oh, wow.
There's also a modified flap designed specifically to preserve the internal iliac or hypogastric vessels for viability.
Now, you would think that with all those major arteries running through the pelvis, arterial hemorrhage would be the biggest intraoperative fear. But the text emphasizes a different vascular danger entirely.
It does. Severe intraoperative bleeding in the pelvis is almost always venous, not arterial.
Why is that?
The pelvis is lined with massive, intricate venous plexuses. Arteries have thick muscular walls. If you cut an artery, it can vasospasm and clamp down to restrict flow.
Okay.
But veins are thin-walled and valvulus in this region. If you tear a pelvic venous plexus, it retracts deep into the cavity and bleeds profusely.
That sounds like a nightmare.
It is incredibly difficult to isolate and ligate. Furthermore, because of the extensive manipulation of the iliac vessels during these resections, deep vein thrombosis is a massive, life-threatening post-operative risk.
It's just a cascading series of risks. So let's move from the complex, multidimensional ring of the pelvis down to the axial loading of the lower extremities.
Right. This is where dynamic biomechanics truly takes center stage, because the femur and tibia have to absorb the sheer impact of human locomotion.
And the distal femur and the proximal tibia are the absolute most common sites for osteosarcoma, correct?
Yes, they are. Fortunately, distal femoral endoprosthetic reconstruction is remarkably successful today. And that success is a direct result of modern materials engineering.
Right, because early prosthetics would just, fatigue and snap under the repetitive stress of walking.
Exactly. Now, surgeons are using heavily forged components in modular systems. It's essentially high-tech, medical-grade structural assembly right in the OR.
So they can customize it on the fly.
Yes, allowing the surgeon to perfectly match the patient's exact resection length and anatomical geometry.
But again, the hardware is useless without the biological envelope. Soft tissue reconstruction in the lower extremity is vital.
It is.
For example, after a massive resection around the knee and thigh, surgeons will often utilize a sartorius muscle transfer. They detach the sartorius from the anterior superior iliac spine, mobilize it, and literally fan it out over the femoral vessels and the metallic prosthesis.
It's brilliant. You are taking a local muscle and repurposing it to act as a living, highly vascularized shield.
Yeah, it protects the major blood vessels from eroding against the metal hardware.
Right, and it brings a rich blood supply to the skin incision to prevent necrosis and infection.
There is also a highly unique case study in the text that perfectly illustrates the extreme limits of lower extremity salvage.
Oh, the calcaneus case.
Yes, it details an osteosarcoma of the calcaneus, which is the heel bone. Historically, a malignancy in the heel is an automatic below-knee amputation, right?
Right. You cannot salvage a foot without a heel to strike the ground.
But in this case, the tumor was entirely confined to the bone, and the patient had a 100% tumor necrosis response to their neoadjuvant chemotherapy.
So instead of amputating, the team performed a wide resection and implanted the world's only reported calcaneal prosthesis.
That is amazing.
The biological golden rule that made that salvage possible was the management of the plantar, flap the skin on the bottom of the foot.
Right.
For an end-bearing stump like the heel, the quality of the tissue is vastly more critical than the quantity. You absolutely require thick, robust, highly vascularized plantar skin that has evolved to withstand the dynamic, compressive, shear forces of full body weight with every single step.
Because if you just cover a heel prosthesis with a thin skin graft, it will ulcerate immediately.
Exactly.
It is a stunning example of pushing the boundaries. But, this textbook is also profoundly realistic. It outlines the heartbreaking scenarios where, despite all our biomaterials and surgical skill, limb-sparing surgery simply isn't an option. When does the math dictate that an amputation is the only responsible choice?
Well, amputation remains indicated in a few strict clinical scenarios.
No.
First, local recurrence, where limb salvage has already been attempted and failed.
Makes sense.
Second, tumors that are actively invading major blood vessels, which fundamentally compromises the ability to achieve clean margins while keeping the limb viable.
Okay.
Third, tumors with major nerve involvement. For instance, a sarcoma in the popliteal space that aggressively engulfs the tibial nerve.
If you cut the nerve.
If you resect the nerve, you leave the patient with a flail, insensate foot, which is functionally worse than a modern prosthesis.
Wow.
And finally, severe soft tissue contamination.
And that brings us back to the stark warning we opened with, the biopsy.
Yes.
This is where early, seemingly minor medical interventions entirely dictate massive surgical outcomes. Are you telling me that a doctor simply trying to diagnose a tumor with a needle could accidentally doom the patient to an amputation if they poke the wrong spot?
I am. If a doctor sticks a biopsy needle into a highly malignant tumor and pulls it out, they are physically dragging microscopic cancer cells all along that needle tract.
Seeding the cancer.
Yes, seeding the healthy muscle and subcutaneous tissue all the way to the skin. And if an outside physician places that biopsy tract, randomly say, traversing a major uninvolved muscle group or crossing over a neurovascular bundle, the orthopedic oncologist later has to resect that entire contaminated tract.
Because that tract is now considered part of the tumor.
Right. which means the surgeon has to take all that perfectly healthy muscle and tissue along with it to achieve oncologic margins.
Which could make saving the limb impossible.
Exactly. The inviolable rule of orthopedic oncology is that the biopsy tract must be positioned meticulously along the precise line of the future utilitarian surgical incision.
Oh, I see.
If it is planned correctly, when the definitive limb-sparing surgery occurs, the surgeon can just excise the skin, the biopsy tract, and the main tumor en bloc as one continuous, undisturbed anatomical piece.
But a poorly placed cross-compartmental biopsy can turn a highly salvageable limb into an unavoidable amputation purely due to iatrogenic contamination.
Exactly.
It is a chilling lesson in surgical foresight. All right, well, as promised for our medical learners out there, we are going to do a quick clinical reasoning exercise to synthesize everything we've covered.
Good idea. Let's test the application of these principles.
Yeah.
Here is the scenario.
Okay.
You are evaluating a patient with a known renal cell carcinoma metastasis in the proximal femur. It meets the criteria for an impending pathologic fracture.
Okay.
What is the correct sequence of surgical steps, and what specific material must you use for the skeletal reconstruction? Let's walk through the logic.
All right, let me reason through this live. Renal cell carcinoma metastasis, that means the cancer is systemic. It came from the kidney.
Right.
Because it's systemic, a biological cure from the surgery is completely off the table. Our goal is local control and immediate structural stability to prevent that femur from snapping.
Spot on.
Sequence-wise, we have to get the tumor out first. We create a window, use hand curettes, and critically, we use the high-speed burr to induce thermal necrosis in the margins.
Excellent.
Now, for reconstruction, because the patient has systemic disease, potentially undergoing active chemo, their natural bone healing is severely compromised. A biologic graft would take months to incorporate, if it ever does.
Right.
We need immediate weight-bearing stability today. Therefore, we absolutely cannot use biologic grafts. We must use cemented internal fixation PMMA cement because it cures instantly and provides rigid mechanical support.
Perfect. You prioritize the patient's systemic reality and match the biomechanical solution to their immediate functional needs.
Well, we have covered immense ground today.
Yeah.
We analyzed the historic biological shift driven by Enneking's fascial staging that moved us away from automatic amputation.
Well, we did.
We broke down the divergent surgical philosophies between treating a primary sarcoma and stabilizing metastatic bone disease. And we waded into the volatile, multidimensional anatomy of pelvic resections and the intense biomechanical demands of rebuilding the lower extremities.
It truly is a testament to the relentless pursuit of improving patient outcomes, merging profound anatomical knowledge with advanced structural engineering.
It really is.
But as we close, I want to leave you with a more philosophical concept to ponder on your own.
I love a good paradigm shift to end on. Let's hear it.
As the boundaries of modular endoprosthetics, customized 3D-printed titanium implants, and advanced vascularized muscle transfers continue to evolve at lightning speed, we are rapidly approaching a future where the line between human tissue and synthetic implant is completely blurred.
Wow, yeah.
Think deeply about the implications. If a surgical team can replace 20 centimeters of your femur, reconstruct your entire knee joint with forged cobalt chrome, and strategically transfer your surrounding muscles over those synthetic parts so that the leg functions perfectly, it forces a profound question. Which is? We are essentially building the ship of Theseus out of titanium and living polymer. At what point does this level of structural engineering force us to fundamentally redefine what constitutes a human limb?